Can I just welcome everyone to another webinar about medical research, COVID-19, and the vaccinations. My name is David Bourgeois. I'm the Executive Director of Business, Western Sydney. We are huge supporters of what is happening, the work that's being undertaken over at the Westmead Institute for Medical Research. They are at the heart of that huge Westmead precinct, and we've been quite involved working with Professor Tony Cunningham and others for a number of years now, trying to support the good work they do. And I guess initially that was because Western Sydney has a jobs deficit and a deficit in knowledge jobs and higher order jobs. And so some of the smartest jobs in our whole region are actually at Westmead, and we see that as very much part of our future. And today, we're doing this on a very interesting day because the Premier has just announced that there's a new health order. We're going in now to our third week of a lockdown, and the restrictions are increasing. And this has got a huge impact on our community, and everyone's interested in this. So we've got, I think, a few hundred people who've joined in today to be part of this. So I'm going to say very little other than thank you, Tony, and the team over at Westmead for the great job you do. We know that of your 5 big research areas, 2 of them are actually right in this area, virus research and immunology. So you are seen as the experts in our region on this, and I know you're working on this every day, and so we're really keen to hear from Tony and Sarah. And to introduce you and to do our welcome and everything is Ivan Power, who is a proud product of Western Sydney, having grown up just down the road in Northmead, and he's had a career working around the world, and he's bringing some of that expertise and passion and energy to support and drive the foundation that's been established to help Westmead Medical Research Institute. So Ivan, I'm going to hand over to you to conduct this webinar.
Thank you, David, and thank you to Business Western Sydney for hosting us for yet another session. As David said, my name is Ivan Power. I'm a director of the Westmead Institute for Medical Research, or WIMR, as we call ourselves, and I'm the chair of the foundation out there. I'd like to begin just by acknowledging the traditional custodians of country and their connections to the land on which we gather remotely, and we pay our respect to their elders past and present. No doubt, as David said, you've heard the news this morning. We're at a really key moment in Australia, and particularly in Western Sydney. Our objective today is to help you sift through the huge volume of COVID-19 information that's coming your way and that has come your way, especially as it relates to vaccination. These are issues that are fundamental to your health, welfare and prosperity, but also to that of your families and your communities and the businesses that you might run, own or work in. We'll be going through a range of issues, looking at data from other countries who've had a different COVID experience from Australia, how the virus is actually changing as it moves around the world and talking about these variants, how vaccination actually works and protects you and those around you, and also the risks associated with vaccination. We're not aiming to give you specific medical advice. We're not aiming to predict the future. We're certainly not going to comment on policing or political matters. We just want to ensure that you as leaders have a very solid base of information, the opportunity to ask some specific questions from global experts in infectious diseases and COVID, and really importantly, some clear ways of being able to communicate this to other people. We've been doing this in some specific sessions for some quite large employers who found it pretty useful. So those of you who enjoy what we see today and want to find a way to get it into your own workplace, please get in touch. No doubt there's plenty of people on this call who may have already been vaccinated or have got one shot. You might think that because of that, you're safe and your job is done. Well, it may be that you are safe, but we do hope to convince you by the end of this that your job's not quite done. There's actually more that you can do for the battle against COVID. The people in our workplaces and our communities often look to us as business leaders for reliable advice and information at really key moments in their lives. Helping them find ways of reliably filling the information vacuum that relates to COVID and especially to vaccination is really one of those moments. And it has implications for them as well as for all Australians. We're really fortunate this afternoon to be joined by 2 of Australia's most experienced and preeminent medical scientists in this field, as David said, namely Professors Tony Cunningham and Sarah Palmer. Tony and Sarah have had distinguished global careers at various times fighting on the front line against the AIDS epidemic in the United States, and Australia, and particularly Western Sydney, is now so fortunate to have them back as co-directors of the Centre for Virus Research at WIMR. They're also part of the Faculty of Medicine and Health at the University of Sydney. For those who don't know, WIMR and Westmead more broadly has been a really key component in Australia's battle against COVID. We've been involved in almost all aspects of the public health response, from testing through to tracing to treating sick patients and in the development of vaccines. In fact, Tony and Sarah are working on the development of a second generation vaccine for COVID that's focused on elderly and immune suppressed patients for whom standard vaccines might not be sufficient right as we speak. Just a reminder to everyone that we're going to leave plenty of time for questions at the end of this session, which you can log using the chat function, which you'll find on Zoom. Sarah, starting with you at home today, we often start these sessions noting by how fortunate that Australia has been with COVID relative to the rest of the world. And whilst that's still true with relative levels of illness and death, it appears that the dynamic has changed somewhat in terms of how the disease is actually spreading. Maybe give us a bit of an insight as to what's happening overseas these days, starting with developing countries and also what's going on in developed countries.
Sure. Thank you, Ivan. Yeah, so in many developing countries, such as the UK and the US, are starting to open up and remove restrictions. And this is really due to the fact that they have advanced vaccination programs in which 50% of their population is fully vaccinated, and then up to 70% of their population has received at least one vaccination. But as people start to move about in these countries, we are also seeing a spread of the virus happening as well. And the virus that is spreading in both of these countries is the Delta variant. This variant is highly contagious. It's also 60% more infectious than the other variants. And we are seeing an uptick in the Delta variant infections in both of these countries. But there's a difference in severity of disease, hospitalization, and death in between people who are unvaccinated compared to people who are vaccinated. So there's a difference in how this variant affects those who are unvaccinated. And a recent report by the infectious disease specialist in the United States, Dr. Tony Fauci, he just reported that of the over 99% of deaths that are related to recent COVID infections, all of these deaths have been found in unvaccinated persons. So really, in developing countries who have reasonable amounts of vaccines available, there is a choice, and there's a twofold choice. The first choice is, how do we develop immunity towards COVID? And the first choice to develop this immunity could be through vaccination. The second choice could be through natural infection. But with natural infection of the Delta variant, this could lead to severe disease and hospitalization, and in some cases, death. So we do have a choice how we choose to develop immunity towards this virus. In developing countries such as Indonesia and India, these countries are severely suffering and acutely suffering from this COVID pandemic. And this is due in large part, to the low vaccination rates in these countries, and also to the less advanced healthcare systems that they have. So these countries are facing an increase in infections, and they're facing an increase in infections of the Delta variant as well. And in fact, the catastrophic surge in cases and deaths that we're seeing both in Indonesia and India are a result of Delta variant infections. So these developing countries who don't have large amounts of people vaccinated are really experiencing a very severe pandemic at this point. But this also has implications for the world, because as the virus replicates in unvaccinated and partially vaccinated people, it provides the opportunity for the virus to mutate and to develop more infectious and more pathogenic variants. So overall, Ivan, what we are seeing is a global race between vaccination and variants.
Sarah, thank you. Tony, I'd be really keen, listening to what Sarah's just had to say, could you maybe unpack for us a little bit about, firstly, how viruses actually mutate and vary, but secondly, maybe tell us a little bit about the Delta variant itself, relative to the COVID that we saw emerging here in Australia when it was last actually, spreading at any rate in the Sydney community, more than 12 months ago. Could you maybe just unpack those two things for us?
Yeah, as Sarah has indicated, when we first looked at this virus, we thought that it wasn't going to mutate very much, unlike flu. That's proven to be incorrect. And we know that what was called the UK variant, the alpha variant, was 50 to 100% more spreadable than the original one out of Wuhan that spread around the world and originally affected us. And then Delta is 60% more spreadable than this. And as Sarah said, we're seeing more cases in young people, and we're also seeing cases of increased cases of serious illness and death, to such an extent that some of the ICUs of major hospitals in Sydney are starting to fill up. And that's the fear. People who think it's just the same as last year are wrong. There is a risk that if this gets away from us, that we might actually have that particular problem. Now, why do you get variants like this? Well, the virus, if you think about it teleologically, wants to, in essence, spread. It wants to infect more people. And it does this by altering the structure of that spike you've seen on the virus. Looks like a little spike thing floating across your screen on the ABC. The tip of that spike binds to the cells that it infects. And this virus has managed to change its spike so that it grabs cells more tightly. And that's what these variants do. The other concern we have is that vaccines protect against infection and disease, and they do protect against infection, not completely, but certainly they protect against disease by producing antibodies which interpose between that spike and the cell itself. And the worry we have is whether there are sufficient changes in that spike that might actually reduce the effectiveness of our vaccines. Fortunately, that's not true with people who are fully immunized, and that's why you need 2 doses, because 1 dose of the vaccines is only 33% effective, whereas it was well above 50% effective against the original strain. So the Prime Minister today was pushing people to have their second vaccine as quickly as possible. You'll get some protection against disease. You'll get some good protection against serious illness with 1 immunization. But when it comes up, you need to have your second injection as soon as you possibly can. Fortunately, this Delta strain doesn't seem to be as evasive of vaccines as the Beta strain in South Africa, which hasn't penetrated here. So the vaccines are going to work. We might need boosters for variants next year. We might need boosters because the vaccines tend to wear off over time, but for the moment, the best thing anybody can do is get immunized and fully immunized as quickly as possible.
Thanks, Tony. And so, Sarah, coming back to your earlier comment about the race, between vaccines and Delta, really what it sounds like then is that the race is actually vaccinating as much of, firstly, Australia as we can, but secondly, actually the world, in terms of actually vaccinating people as best we can to suppress the virus from being able to circulate and therefore come up with more mutations that become, as Tony's described, more infectious or more deadly, or worse still, both. Is that fair?
That is very fair. So what we really need to see is global vaccination rates increase. Currently, we're at 11% of the population across the globe is fully vaccinated. And until we see this to close to more 70% or 80%, this virus is going to take advantage of those who are unvaccinated or even those who are partially vaccinated. And this is a big worry because we're concerned that, yes, we have the Delta variant, but there could be other variants that would arise due to the virus replicating throughout lots of different immune systems and billions of people worldwide.
So if we move along to vaccines, and Sarah, if I could maybe start with you. Let's pretend you're speaking to my 10-year-old and you've got his attention for a couple of minutes about the COVID vaccine, and you want to describe how the vaccine works and what it does and how it prevents against both infection, about infectiousness, about how it prevents against hospitalization and death. Where would you start?
Well, first I would say to your son, you are the host for this virus. And the one way that we can prevent the virus from infecting you is to have you vaccinated and have your immune system respond so it can protect you from this virus infecting you. And furthermore, this vaccine could possibly reduce the amount of infection that your body experiences. So it prevents you from spreading the virus to your father, who's sitting right here, or your mother. So not only is it protecting you, but it's also protecting your family. So that's really the most important reason to be vaccinated, because you are the host for this virus. And by getting vaccinated, you can not only prevent yourself from getting ill, but you can prevent yourself from infecting others.
And so, Tony, maybe tell us a little bit about how vaccine actually works. You hear some people saying that effectively you're getting COVID when you get vaccinated. And some people even thinking that when you are getting the vaccine, there's a risk that you could potentially get sick or infect other people as a result. Could you just maybe tell us, as someone who develops vaccines, what actually happens when you're being vaccinated and how does that work?
Well, I think the people are probably thinking back to vaccines like measles, mumps, rubella, where we essentially defang the viruses. We make them very mild, and we inject live attenuated viruses, and they don't cause disease. This is not happening with COVID, where there is no current licensed live attenuated vaccines. We're taking little bits of the virus, which is the Novavax vaccine, and it's that spike that everybody is focusing on, and combining it with immunostimulants. With the RNA vaccines, Moderna and Pfizer, we're taking RNA, which codes for that spike, and injecting that into people's muscle. And all of these vaccines flow from the muscle into the lymph node, where they actually induce antibodies and white cells, and both are very important. None of the vaccines are infectious. None of them will get into your DNA. And none of them are likely to produce a COVID-like illness. It just doesn't happen because it's just bits of the virus. It's very much like like the hepatitis B vaccine, which is again just a single protein, or the new shingles vaccine, which is a single protein. We're using RNA to actually code for that, or alternatively, we're putting the gene into another innocuous virus like AstraZeneca, into a common cold virus, and it's not capable of producing a COVID virus or a COVID illness.
Thanks, Tony. Sarah, if we think about then, we've heard lots of things about effectiveness of vaccines. Could you maybe just break down what effectiveness means in thinking about that, as I said, in the context of death, of illness in terms of hospitalization, but also in terms of rates of infection and infectiousness, which of course are two different things?
Actually, Ivan, I think I'll let Tony answer that.
Okay, wonderful. Tony, right to you.
Yeah.
So when there's terminology involved here, and it's sort of vaccine jargon, when we look at the main aim of these vaccines is to prevent disease and death. That is what vaccines do par excellence. They often don't protect completely against infection. So we're all very pleased and delighted that not only does this vaccine prevent against death, that's Pfizer, Moderna, AstraZeneca, the ones that are coming here, Novavax as well, and you're looking at 97 to 100% protection against death. which is spectacular for what we might have expected a year ago. Similarly, against severe disease, well over 95%. Now, prevention against, I often say to people that COVID's two diseases, one in the upper airways in the nose and the other one in the lung. And the one in the lung is the one to fear. So if the vaccine prevents against the disease in the lung, as it does, these three vaccines, you don't get sick, you don't really sick, and you don't die. You may get a mild illness, or you may get asymptomatic infection with the alpha strain, about 10 to 15%, with the delta strain, about 15 to 40% will get asymptomatic infection. What we mean by effectiveness is that in field studies, we're looking at how good the virus is in preventing disease and infection. And it's a check on what we see in the trials. The trials are only 30 to 40,000 people. It's still a lot of people. But when you start looking at populations, you're looking at millions. So you'll hear people talk about efficacy. That's a term applied to trials, and effectiveness is a term applied to populations. Does that help?
It certainly does, Tony. And when we're thinking about that then, so if I'm vaccinated, what you're saying, I suppose, is vaccination doesn't mean that you are 100% guaranteed that you won't get the virus.
Correct.
It does significantly limit that, and I'd be interested for some of the numbers here, but what it certainly does is limit your ability to be infected. It certainly greatly inhibits your ability to then infect others, even if you were infected.
Correct.
And it's almost, it's very, very, very effective, much more than many other vaccines that we've seen in our quest of vaccinating populations for other diseases in terms of preventing against serious illness and death. Is that fair?
Absolutely. You've got this gradation, as you very nicely pointed out. And I'll give you some of the figures. People may not remember them, but they should remember your gradation, and that is almost complete protection against severe disease and death, lesser protection against spread, and lesser protection with the Delta strain. So the figures are these, that when we're dealing with the alpha strain, we are looking at both vaccines, AstraZeneca and Pfizer, somewhere in the 85 to 95% protection against spread. Unfortunately, with the Delta strain, it's not quite as good as that. Pfizer is 88% and AstraZeneca is 60%. So, but you don't get severe disease. That's the key issue that we're talking about here. Delta is more spreadable, but you can imagine if you've got 80% of the population immunized, and you reduce the amount of spread even by 60% with AZ, which will be, about a quarter of the vaccines we have, you're going to stop those viruses circulating, and that will enable us to get back to a relatively normal society with businesses opening and without having these surges and lockdowns.
Absolutely, and I would agree with Tony. It is really to reduce the circulation of the virus within the community is why we are being vaccinated, but also is to protect our loved ones and our family.
And I'll just say one thing about families. Spread within families is less protected by the vaccines than in the general community. There's still some protection, it's over 50%, but and that's with full immunization, but the intimacy of family connection in the same house is substantial. And that's the reason for these discussions about southwestern Sydney limiting big families from mingling with each other, because you'll have as you may have heard, the Delta strain in one family infects everyone in that family, and you only need to get them to mix with another one, and then you've got another family infected. So that's the reason why we've heard the Premier and the Chief Health Officer try to convince people not to mix families.
And one other thing to understand about the Delta variant is that a recent study that came out of Guangzhou, China, showed that this variant has 1,000-fold more particles in your upper respiratory system than the original infecting Wuhan strain. So in other words, even if you are vaccinated and you become infected, you could be carrying a lot more particles in your upper respiratory system than with the Wuhan strain, which makes you more infectious to others.
Sarah, that's wonderful. And coming back to that point, and also Tony's point, so just to be clear, the infection within families is because of the intimacy of contact that you have within that family group in terms of living at very close quarters and the issues of inside and respiration. That's the issue with the spread within families. Is that right?
That's
aerosol spread. Mm-hmm.
Yeah. The minute you go inside, it's 30% increase in infection. But with your families, it's even greater because you're much more closer to them.
Yeah, right.
So you're okay surfing this morning, Ivan?
That's right. Moving on now to risks, which I think is really, really important that people are aware of these issues around the risks with vaccines, but in a very balanced and even-handed way. Maybe Sarah, if it's possible to start with you about risks. There's been a huge amount of comment on about what the risks are of vaccination. In some cases, as we've heard, that it changes your DNA, that it gives you bits of the virus, which I think Tony's already dealt with. But maybe just tell us a little bit about how it is people should think about risks and what the risks are that have been associated with the vaccines that we're actually seeing distributed in Australia. Sure.
So the risk with the Pfizer vaccine has been not an immune response. I'll say an immune response, but a actual. Tony, help me here.
Allergic
response.
Anaphylaxis.
Yeah. So with the Pfizer vaccine, it's been an allergic response, and this typically takes place within 15 to 30 minutes after you're vaccinated. So that's why when you're vaccinated with the Pfizer, you're asked to sit for 15 to 30 minutes. And if you've had any sort of allergic response, say to a bee sting or anything like that, just let the people know there and they'll actually watch you for 30 minutes. Those of us who haven't had an allergic response, they watch us for 15 minutes. When we move on to the AstraZeneca virus, there has been a clotting syndrome associated with this vaccine, but it's very low numbers. So for those people who are 16 older, this clotting syndrome is really about 2 cases in 100,000 people. If you're less than 60, it's more like 1 case in 100,000 people. And as Tony likes to say, those people who have sadly passed away from AstraZeneca, it's really a case of maybe 3 in a million or 1 in a million. So you'd have more chance of being struck by lightning than dying from this clotting syndrome, which is associated with the AstraZeneca vaccine. And what we know is that if people pay close attention to whether they have a stomach ache or a very serious headache, and they go and talk to their GP right after they have these symptoms, that this can be mitigated very quickly. There is treatment for this clotting syndrome. And so the risk from AstraZeneca is very, very low. And Tony, you may want to add to that as well.
Yeah, if I can, Sarah, I agree with you. I think that one of the things that's really important is that this is a very special type of clotting syndrome. It's not normal clots. I often get asked by people, oh, I had clots. Clots are very common. And in fact, in the trials of AstraZeneca, there were fewer clots in the vaccine group than the placebo group. This is a specific syndrome which is induced very rarely, as Sarah said, in 2 to 4 per 100,000 people, depending on age. And we now, in the first case, everybody was really scared because it had a 25% mortality rate. That's declined in Australia to under virtually, what have we had? We've had about 2 deaths in about 40. So it's very low now, and in fact, it amounts to a death rate of 1 in 2 million is the latest figure that I've heard. So you have to really weigh up 1 in 2 million versus if you're over 80, a chance of 15 to 20% of dying of COVID if you're unimmunized. So that's the way that our expert scientists have advised the government, and that is, as you rise above 60, the death rate increases 2 to 3-fold between 60 and 70, 5-fold over 70, and then 20-fold over the age of 80. And if you have transplants, it's 4-fold. So obviously, if we've got AstraZeneca around, then it's critical that we immunize people. And as you've heard, we've got 40 people in hospital and 7 in ICU, and that could be prevented with AstraZeneca. And as the Minister for Health pointed out, in the West Hoxton party, there were 20 people, 6 did not get infected and 14 did and got disease, and the 6 people without infection or disease had been immunized. And that's a local example of some of the things that we've been talking about.
And one of the things we should bring up, Ivan, is that with the Delta variant, the incidence of severe disease and death increases.
Yeah.
So even the numbers that Tony gave were for the original Wuhan strain. And with this Delta variant, it's much more severe. And the case of, and the rate of death, the death rate from this variant is much higher.
Seems to be in younger people too, doesn't it, Sarah?
Exactly. Yeah, it seems to be affecting younger people severely.
And just one thing I think that is important here. So Tony, looking at those numbers that you gave us earlier, the risk of clotting from AstraZeneca being very, very, very low is actually even lower in younger people. The reason why the health advice has been given is not because the risk of clotting is higher, but because the risk of issues with COVID is higher in older people. That's fair.
No, well, that's not quite true. The risk of getting the immune clots, and I say these are the antibody-induced clots, is lower in older people, but it's only marginal. But you have to match that up against the risk of death from COVID, and so you're weighing them up, one against the other, and that was the reason for the over 60 age group. Both 2 reasons. One is there's a marginal increase in incidence of clots under the age of 60, and this decreases over 60, but the risk of severe disease and death goes up markedly. And when you're comparing those two, that's what the balance of risks is all about. So often not mentioned because people just talk about the clots. They don't talk about clots and COVID together in the one breath. Right.
Thank you. Maybe moving on, I'm conscious we need to leave quite a bit of time for questions as well. As you're describing earlier, we heard the Prime Minister talking about a time after COVID or living with COVID. We've now heard that quite a bit in news conferences this week in New South Wales. Tell us a little bit about then, in terms of what it is that would be required in order for us to be seriously contemplating a path out of COVID in terms of vaccination levels and other things, particularly as regards the movement of people in and out of Australia or between states.
Well, the estimates that have been made by the Chief Health Officer and other expert epidemiologists are approximate, but the figure that we're aiming at, and certainly we'll need to look at this very carefully to see if this continues to hold up with this spreadable Delta strain, are about 80% of people immunized. And I think that there's a degree of common sense now starting to appear, and that is that people who are fully immunized, fortunately like me, because I'm on a medical campus, can actually have a little more freedom than people who are not in terms of the types of quarantine that they undergo. So 14 days quarantine for people who are fully immunized is probably inappropriate, and home quarantine could be utilized, and you need to give people a bit of an incentive to be immunized as well. But I think the government certainly got the message and is accelerating access to Pfizer and others, that we have to get ourselves immunised very quickly. And it's great to see we're up to 32% single dose and over 10% dual dose, and going to go up still further. But what I see is that we're going to have to play this very carefully until we're much more fully immunised towards the end of the year. I hope that common sense applies in terms of movement around Australia, particularly for people who are fully immunised, and these digital vaccine passports come in. That makes a lot of sense to me. Coming in from overseas, you have to be sure that people are immunised with the right vaccines. There are some vaccines, which I won't mention, that are not as effective as the ones that we're using. And of course, there's always scope for people presenting themselves as being immunised when they're not. So this will have to be very carefully screened. Greece is doing this. They are asking for people to be immunised and tested when they come into the country, because their economy is under such pressure.
Yeah, I would agree with Tony that really what we're looking towards is 80% vaccination rate. But not only in Australia, we need this vaccination rate globally in order to really combat this pandemic. So these vaccines have to be made available to developing countries. Yep. And right now they're not available in a lot of developing countries. And we're seeing the ramifications of that with surges in infections and deaths. So we really need not only Australia vaccinated, not only Europe and the United States, but also developing countries as well.
I often say, if I was in Indonesia, I'd be itching to get my hands on AstraZeneca, and it's good to see that 1 million doses are going to be shipped there from Australia in the near future. And that's probably what CSL will keep doing, keep making AstraZeneca and hopefully supplying the Asia Pacific.
And just picking up on a point you were both talking about there, it seems that in many other countries and in some regions of the world, like within the EU, that there is now kind of, a two-speed communities of people as regards the movement of people between countries, that it is, if you are vaccinated, it means that you have significantly greater ability to move between some of these regions and between some of these countries. Is that right?
Make a comment about that, I think that it might have been Fauci, maybe Sarah can correct me here, but the comment being made that if I went into low vaccinated areas, and the USA is certainly a two-speed economy as far as vaccines are concerned. There are states that are poorly vaccinated in the south, and his comment was I'd be still wearing a mask and carefully socially distancing if I went into those areas. And we've heard things said about that the regulations may apply differently, I think in Singapore, depending on whether you're coming from a country of low incidence or high vaccination versus low vaccination and high incidence.
And Sarah, it comes back to something that you mentioned at the beginning of our session here, which is really around, given the mutations, the movement of people around the world, we've been so fortunate here in Australia that, we've kind of hidden on our island nation here from the effects of COVID for nearly 12 months relative to many parts of the rest of the world. But given what's going on in the rest of the world and the way that the virus is circulating, unless we never open our borders, it's likely, as you said, that people are going to have to acquire immunity at some point in some way. And I think you outlined that it is this race between acquiring the immunity with vaccination, between acquiring the immunity in some other way. Is that fair?
That's fair, yeah. So we really have two choices. The choice is whether we acquire immunity from vaccination or acquire immunity from infection. And frankly, in my mind, I think the second, acquiring the immunity from infection, is not really the best way to go, especially as we know there's long COVID. And this is something that we haven't touched upon, but a lot of people who are infected with COVID-19 experience what they call long COVID. The CDC has said that about 30% of people who are infected with COVID-19 experience this. And it means that once you're over your initial infection with the virus, you still have very serious health ramifications, such as difficulty in breathing. So there can be, and weakness. So there can be real ramifications from acquiring your immunity from infection, as opposed to acquiring immunity from immunization. And also, I think in the States, there are areas in which people who are vaccinated are allowed to go. For example, sports arenas and things like that, attending concerts. As long as you are vaccinated, some concerts are requiring people to be vaccinated before they can attend. So really, we will become a dichotomy of those who are vaccinated and those aren't, unless we ensure that all of the world becomes vaccinated.
And just picking up on that, Sarah, vaccination, with your comments to long COVID, vaccination, because vaccination helps you deal with, firstly, infection, but secondly, actually with hospitalization issues with that, vaccination makes long COVID obviously significantly less likely, as well as other issues associated with COVID.
Absolutely. So there's very rare cases of long COVID in people who are vaccinated. I don't even think I've read of a case yet. But as those who have been infected with COVID-19, 30% of them experience some sort of long COVID. So yes, vaccination prevents that as well.
Cool. Now, I'm conscious of time. We've got a huge audience on here today. There's quite a lot of questions. I've tried to deal with quite a few of them as we're going along. But Tony and Sarah, if I could maybe give you a couple of rapid fire questions, if I could, so we can go through this. I think it's really important that we get the opportunity to answer some of the questions that have come directly from people. Quick one from Warwick, which is around the 80% vaccination rate that we think is required to get this herd immunity. Does that include under 18s in that number?
Not at this stage, no.
And given variants, Tony, I assume that, you know, in the fullness of time, and we're seeing this in other countries, that actually there is a likelihood that in time that we may need to see
Absolutely. I was going to add that, I think, with the Delta strain, because it is moving around quite a lot. We know that the 20 to 40-year-olds, the epidemiologists will tell you this, are the people who are actually spreading the virus most. But sure, I think we know Pfizer's been licensed in the USA for 12 to 18-year-olds, and I would be very surprised if we don't ultimately do that here too.
So is Moderna. So both Pfizer and Moderna are licensed for 12 to 18-year-olds in the United States, and they are vaccinating. They're holding vaccination clinics at schools. So they are vaccinating younger people in the United States.
Okay. Now, quite a few questions on here about the AstraZeneca vaccine, if I could deal with that. First one is, we've seen some comments from the Prime Minister around reducing from 12 weeks to 8 weeks the period for the second shot. Any comments on that as regards efficacy? You know, and any comments of that? I know that the medical advice I don't believe has changed, notwithstanding his comments.
When we reanalyzed when it was reanalyzed the data from the AstraZeneca trials, it was pretty clear that the optimal efficacy of 82% was achieved with 12 weeks, and it was actually significantly less if there was a 4-week break. However, in urgent situations, there is some advice being given to give it at 8 weeks, and I think the Prime Minister actually said that. And one could make a case, because I mentioned previously, one vaccine is only 33% effective against the Delta strain. You could make the case that it is an urgent situation to get people immunized with two doses. It probably will marginally decrease the efficacy of the second dose, but it's going to be better than just relying on one alone.
That's true, but we don't really know whether 8 weeks is a good time period to get that.
No, we don't. The data has been analysed by AZ, and they've done this from 4 weeks out to 12 weeks, and 12 weeks is optimal for 82%. So it's going to be a little bit lower than that at 8 weeks. And I've seen the figures, but I'd need to go back and check them for you. I think it'll be a little under 80%.
So what some
better
other
than 33%.
and what some other countries are doing, Ivan, is they are actually starting a vaccination with AstraZeneca and then following up with a second vaccination with Pfizer. Now that's not being done here in Australia, but it has been done in the UK and in Spain and other European countries where they were concerned about the Delta variant increasing. And so they followed up with the second vaccination with Pfizer. And they found that the antibodies after a second vaccination with Pfizer from the first vaccination with AstraZeneca were higher than when you had 2 AstraZeneca vaccinations.
So the Australian authorities have agreed with that, but have said that because we don't have efficacy data yet, they have not recommended that so far. There are 4 clinical trials in progress, and presumably if they come out with efficacy data which works, then we'll start to see. And we have more Pfizer in the country, because remember, we've got a dearth of Pfizer and we've got an excess of AstraZeneca. Then exactly what Sarah says is likely to come to pass, I think.
Okay. Moving through the questions then, boosters, as it is that as we get flu boosters and as we get boosters with other vaccines, I expect that Tony and Sarah, that we'll see a world where we will be getting boosters for COVID, particularly to restart our immunity, but also to deal with variants. Is that right?
Sarah, yeah.
That is absolutely correct. I think we will be facing boosters. When we're looking at the extent of immunity from these vaccines, it's good, but we don't know how long it will last. And there are some indications that it may not last forever. So I think we will be requiring boosters, and not only boosters to increase our antibody rates, but also boosters to combat possibly new variants. So some vaccines may have to be tweaked, and that these boosters are a bit different so that they actually combat new variants that could arise as this virus mutates.
So Sarah and I were both racing to answer this because this is our interest, and an antibody declines over time, and we're interested in what happens with the white cells because they're very important in aging people and in memory, because we know that with SARS-1, the white cell immunity lasted for 6 to 17 years and antibody was gone in 1 to 2. It's probably a combination of age, new variants, and also other factors that will be important in that decline. So if you've got new variants and you're older, then the likelihood is your vaccine protection will taper off over time. We only know that from short-range antibody studies at present. However, the chief of Pfizer said he was expecting, and maybe he just wants to make money, but I think not, that boosters are probably going to be necessary next year. Interestingly, we've not found that the Delta strain is less susceptible to our vaccines if you're fully immunized against disease and death. So although the companies are preparing boosters against the variants, we can be reassured that you can continue to have the current vaccines and feel safe.
I think a really important question that's come through here, I have heard this quite a lot from people in various circles. A teacher friend of one of our attendees says she's not going to be vaccinated as her son-in-law has convinced her and their whole family that a microchip is inserted during the vaccination process. She's really concerned because this person is actually going to be teaching in schools. What do you have to say about that?
Microchip in these vaccines. Well, first of all, we don't have the technology to do that. There's no way we can do that in a vaccine. We have no way to introduce a microchip in someone's arm from a vaccination. If you look at the needles that are being used to administer this vaccine, they're tiny. You hardly even feel it go into your arm. So there's no way we can do this. And secondly, really, what you're being tracked with is your cell phone. So if you're worried about being tracked, then turn off your cell phone. But it's not the vaccines. There are no microchips in these vaccines. You are absolutely safe from that.
Okay. Now, lots of comments on here as well about pregnant women, about women who may be pregnant soon, about fertility, and about breastfeeding. Sarah, any comments on that in terms of vaccination for people in that particular category?
Sure. So what we have seen is that in pregnant women, that COVID-19 is a much more severe disease. So if you are pregnant, you should get vaccinated. And if you're planning to get pregnant, you should be vaccinated. There's been shown no effect to the fetuses by these vaccinations. So it's really to protect yourself and your fetus, it would be best to be vaccinated. As far as, what was the other question? I'm sorry.
Fertility, and there's no evidence for it.
These vaccines do not affect fertility in any way. No, there's no way they really can. So they're just a small fragment of the virus, and it's educating your immune system to fight the virus, and it does not interfere with your fertility in any way. As far as breastfeeding, Tony, I'm not...
No, it's fine with breastfeeding. That has been looked at. I think it's worthwhile emphasizing to people that when you get your intramuscular injection, the vaccine drains into the local lymph nodes, under the arm, and it doesn't go any further than that, and it doesn't really survive beyond a few days. And that's why you do get those side effects in the first few days. Then you produce your antibodies and your white cells, and the concern might be that, like AstraZeneca and the immune-induced clotting, that maybe those antibodies might affect something else. And that's something that our regulators are looking very closely at all around the world. And as Sarah said, there's no effect on fertility, there's no effect on breastfeeding, unfortunately, because it is so nasty in women who are pregnant. It seems to be safe so far in that. That's and the recommendation is, again, balance of risks. It's a very nasty disease in pregnancy, not quite as nasty as if you're over 80, Ivan, but still.
No, it's very serious if you're pregnant. And it's really important to be vaccinated to protect yourself and your fetus.
We've got very quickly, a couple more last questions, if we may. If you have a choice of vaccines, should you, or people saying which, actually, maybe let me rephrase the questions. Which vaccine should I get is a question that has come through from a couple of people.
If you're over 60, it's AZ, and if you're under 60, it's Pfizer. It's pretty clear what the recommendations are. But that may change as we get more Moderna, Pfizer, and also Novavax. Novavax is a very good vaccine too. But for now, it's very clear. Yeah.
We've got a question here from someone about myocarditis. That there's been some reports of some issues around that occurring as a side effect of the Pfizer vaccine in men. As someone who's prone to pericarditis, is this something that this person should be concerned about?
It's mild and it occurs in young males, and it's reversible, but it's still being more clearly defined. And I think I'm not quite sure what type of pericarditis the person concerned has, but they should really talk to their cardiologist about this. Yeah.
Okay. Given this is a business audience as well, we've got quite a few questions on here about why Australia can't produce the mRNA vaccines as opposed to CSL being able to produce the AZ vaccine. Any thought on that?
Yeah.
I've been heavily involved in that with the state, so I will comment, and that is that we would need to get Moderna or Pfizer here. Pfizer went to Singapore. Moderna might be coming here, probably will be, because it's taken 10 years of research to produce the little fatty envelope that we put the RNA vaccine into. And that only recently there is some capacity to import some of that material, but it's going to take us a couple of years. There's a guy named Colin Putin at Monash, who's working on that. And I think you'll see RNA vaccines here, but as we discussed with the state yesterday, RNA vaccines are not the only vaccines of the future. We need to diversify and diversify beyond just producing flu vaccines, as we've done through CSL in the future. And the government's getting that advice from a number of us at present, believe me.
And I would just say, currently, we don't have the technology here in Australia to make mRNA vaccines, but we will be developing that.
Yeah, Colin Putin is furthest advanced in this, but we need to do more than RNA. We need to be able to produce protein vaccines. We need to produce the immunostimulants. We need a much broader research approach to vaccines, and we're approaching the Commonwealth Government for funding to do exactly that.
Thank you both. Maybe ending our comment here on just before we pass back to David. I think it's always nice to end it on an optimistic note. And I think one thing that's resonated certainly with me as being close to what's going on in this through my involvement at Westmead is that that whilst there's been an incredible amount of issues in relation to COVID globally, that the way that science has actually tackled this problem and the way that we as communities have actually dealt with this problem is really extraordinary. And particularly, I heard Peter Thiel, who many people on this webinar would know is a very esteemed investor in venture capital in the United States, describing that 2020 was actually the first year of the 21st century in terms of many of these technologies that we have been contemplating or thinking about actually now being used at great levels throughout society, and us really embracing these technologies in terms of the way we live and also the way that we actually defend ourselves against some of the risks in our communities. Tony and Sarah, as people who've been involved in these things for many years, how do you feel about some of the progress that we've made over the past 12 to 18 months in some of these areas when you're looking forward into the future and looking then at other people who are looking at getting into science and technology?
Well, I would say it's a very exciting time to get into science and technology, because a lot of the new science, like mRNA science, has been around for a long time, but now we're actually putting it to practice, and it's actually saving lives. So it's a really, sadly, due to this pandemic, it's an exciting time to really learn new technologies and to put them to practice and to see how well the technologies that we've been proposing that may work do work. And so for me, it's a really, really interesting time to work with young researchers to really say to them, look, we could be the next person to develop the next vaccine for the next pandemic. So I think this is really an exciting time to be in science, but not because of, I mean, for me, it's also been a very tough time to watch the suffering from this disease, but to see that science can actually mitigate this disease has been a really positive.
Yeah, I would say I would agree with everything Sarah said, but I think it's a two-edged sword in that this country has done extremely well in listening to its expert scientists and doctors. And so it's wonderful to see the Chief Health Officer get up and say things and being deferred to by the politicians, because people will have much more faith in medical experts. But we've seen some countries around the world, Brazil as an example, where science and medicine has in fact been supplanted by political advantage and fake news. And that has been much more prominent in the past few years than previously. So I think there's a real risk here in non-scientific approaches, and we saw that in the USA as well, and we've seen Tony Fauci pilloried by certain political areas. That is a real worry. Are we still advancing as a civilization, or are we actually going backwards for political advantage?
David, Tony and Sarah, it's just such a privilege to have your insights here. I'll throw back to David. Thank you, David, for providing us with this forum. I know we're right on time now, but Tony and Sarah, thank you so much for all the insights you provided.
Thank you, Ivan, for leading us.
Thanks, Ivan. Thanks, Tony. Thanks, Sarah. And look, it's great to be able to listen to such a fact-based discussion on this issue, because for most people, they look at the media and they get little sound bites and grabs on TV, and you get a little bit of the story. It's really hard to delve deep with the experts, and I think that's the great beauty of these sort of webinars that are now being attended by more people, that we can really delve into these issues, get your questions answered. And I think the other thing that strikes me is that the economic case for investment in research is bigger than it's ever been. And that means by governments, but it also means by us. So if you're from an organisation that's thinking about how they make a difference, and whether it's through regular giving or doing a fundraiser or somehow getting involved to support the great work of Tony and Sarah, then we can help you make that happen, and we will. And I also think, Ivan, these forums are great to actually, I love Sarah's point about how do you actually respond to the irrational person? And some of us think, well, don't respond at all, just don't get involved. I think we should respond and respond with facts. And Sarah's given us a few of them today. So I'm going to use that next time I hear someone at my local cafe tell me that they're not getting it and these are the reasons why. But if there are other companies and organisations that think that it might be some value in trying to connect their workforces and their management teams to the latest research and science and insights, then maybe there's a way of making that happen as well, Ivan. So thank you all. And to our members of the chamber, sorry, we've got this period now of not having live face-to-face events. We've missed the Premier. We had the Premier lined up, we had the Treasurer lined up, we had the head of the NBN. We've had to move them all down a little bit. So I presume that once we get back in September, October, we're going to be super busy seeing you all face-to-face. In the interim, we'll probably do a few more of these Zoom webinar style events. So thank you to the team at the Institute and Ivan for his energy and enthusiasm and passion to make a difference. And we'll see you all soon.
Thank you, David. Bye.